Good morning. My name is Anahita Jalilvand. I am a surgery resident at the Ohio State Wexner Medical Center. I'd like to thank SAGES and our moderators for the opportunity to present this research. Today I'll be discussing tobacco use does not influence anti-reflux surgery outcomes, a 3-year follow-up study. Good morning. My name is Anahita Jalilvand. We have no disclosures. Gastroesophageal reflux disease, or GERD, is defined by when reflux of stomach contents causes problematic symptoms such as heartburn, regurgitation, chest pain, or complications such as erosion, strictures, and Barrett's esophagus. The incidence is increasing worldwide, and currently its prevalence is about 18 to 28% in North America. Laparoscopic anti-reflux surgery, or LARS, is indicated when patients experience symptoms despite maximal lifestyle changes and use of medications with complicated gastroesophageal reflux disease, and if the patients prefer surgery in order to reduce or come off medications as long as he or she are a good surgical candidate. Smoking is associated with the pathophysiology of GERD. Tobacco users have a lower esophageal sphincter resting pressure shortly after smoking a cigarette. Also, smoking decreases salivary bicarbonate production, reducing the rate of acid clearance. Smoking cessation has been shown in patients who are medicated for GERD to improve their reflux symptoms from severe to mild, although this has not been shown if they are overweight. The objective of this study was to elucidate the effect of tobacco use in anti-reflux surgery patients. We hypothesized that anti-reflux surgery patients who are active smokers would have poorer disease-specific quality of life outcomes than non-smokers. To do this study, we performed a retrospective cohort study on anti-reflux surgeries at the Ohio State University Wexner Medical Center from 2011 to 2017. This included 236 patients who underwent either primary laparoscopic anti-reflux surgeries for symptomatic GERD, including partial fundoplications, paraesophageal hernia repairs with fundoplication, or magnetic gastroesophageal junction reinforcement, or LINCs. Patients were then stratified according to tobacco use, active smokers or non-active smokers or non-smokers. An IRB-approved prospectively maintained database was used to collect our demographic variables, preoperative workup including pH testing and EGDs, baseline questionnaires, PPI use, and perioperative outcomes. Postoperative questionnaires were administered in clinic at 1 to 2 months post-op, and long-term questionnaires were given via phone interview at between 2 to 6 years postoperatively. Questionnaires administered were the GERD HRQL, or Gastroesophageal Health-Related Quality of Life, and the GERS, or GERD Symptom Scale scores. This table shows the characteristics of our patients who received primary LARS and compares the two groups. The only significant difference in baseline characteristics were that our non-smokers were older than active smokers by an average of 9 years. Otherwise, there were no differences between groups by sex, race, insurance status, BMI, ASA grade, or PPI use. Similarly, there were no differences in presence or size of hiatal hernia, esophagitis, de Meester score, baseline GERD HRQL and GERD scores, or the type of fundoplication performed. Non-smokers did have more surgeries that included a paraesophageal hernia repair compared to our non-smokers. Here are the outcomes of LARS by tobacco use. There were no statistically different differences, including OR time, length of stay, readmissions, or need for postoperative dilation or redo surgery. Immediate postoperative and long-term follow-up outcomes were also similar between the two groups, which I'll show in more detail shortly. These are the GERD HRQL scores at baseline, postoperative follow-up, and long-term follow-up. Both groups had similar decreases to scores within the normal range, and they both maintained low scores at long-term follow-up without any statistical difference between the two groups. Similarly, GERS scores at baseline and postoperative follow-up and long-term follow-up were also similar, and again, there was no difference between the two groups. Postoperative PPI cessation was 94% and 92%, and remained high at 78 and 69% at long-term follow-up. And again, these differences were not statistically significant between both groups. 82 and 86% of patients said they stated that they would elect surgery again if they had to do it over, and 88 and 87% were overall satisfied with their surgeries. As such, PPI cessation, long-term PPI cessation, and electing to undergo the surgery again or believing the surgery was a success was similarly characterized by both groups. I'd be happy to take any questions, and again, I thank SAGES and the moderators for the opportunity to give this presentation.